Good evening, everybody. The topic for today's webinar is limitations of GeneXPERT and line probe assays with case studies. I would like to introduce our speaker for the session today, our chief guest speaker, Dr. Nikhil Sarangdhar. Dr. Nikhil is a chest consultant with independent practice in Mumbai. He was a former associate professor, Department of TB and Chest Disease, KJ Somaiya College, Mumbai. He's also been the organizing secretary of the NAPCON 2016 in Mumbai, as well as the NAPCON 2020, which was a virtual conference. He's been the organizing secretary of 16 national conferences and 9 workshops, and has been the recipient of 8 prestigious Young Scientist Awards. He's also been the recipient of the NCCP Professor P.S. Shankar, Professor K.C. Mohanty Chest Oration 2020, and has been the editor of is the editor of the NCCP newsletter, the Lung Bulletin. He's also authored 27 chapters in textbooks and 14 articles in journals. Dr. Nikhil, I welcome you and I look forward to this really exciting session.
So thank you. Good evening, everybody. The topic for today is the limitations of GeneXPERT and line probe assays with case studies. To TB diagnosis, we do it by the CRPM way. C is clinical, R is radiological, P is pathological, and M is microbiological diagnosis. Clinical and radiological are subjective or presumptive diagnosis of TB, whereas pathological and microbiological diagnosis are definitive diagnosis of TB, because you can actually see what is happening inside the patient or inside the lesion. So just to ask you, which is the most rapid test to diagnose TB? The first, which I have shown here, is sputum smear for acid-fast bacilli. The second is CB-NAAT or GeneXPERT. And the third is the good old chest X-ray. So I feel of all these, the good old chest X-ray is the fastest because you instantly get a presumptive diagnosis. For decades, it was the basis for TB diagnosis and treatment. Chest X-ray remains the first investigation of choice in any suspected pulmonary or pleural disease. And even in patients with extra-pulmonary TB, it can help you assess coexisting pulmonary lesions. So broadly, you have diagnostic tests for TB classified into 2 types: direct tests, which detect the presence of Mycobacterium tuberculosis in the body, or indirect tests, which measure the body's response to Mycobacterium infection. Regarding our microbiological tests, they can be broadly classified into 4 types: microscopy, that is xenilin and modified acid-fast stains; fluorescent microscopy; then culture, which is your phenotypic test. You have the solid and liquid culture. You have molecular techniques, which is your genotypic tests, such as the GeneXPERT and LPA, which we'll be talking about today, and we have other tests. So coming to culture, you have the solid and the liquid. Solid culture, the turnabout time is 6 to 8 weeks with another few some more time for DST, and liquid culture is much faster with some days for DST. Now, having said that, culture remains the gold standard for TB diagnosis. The advantages of culture is that it fulfills Cox postulates for a definitive diagnosis. That is to say, you have a clear association between the disease and the organism. It provides specific standardized drug susceptibility testing, rendering individualized treatment possible. It differentiates Mycobacterium tuberculosis from other mycobacteria. Cultures are highly sensitive and specific even for extrapulmonary samples. And culture conversion occurs with successful therapy, so it can be used as a monitoring tool. The disadvantages of culture are that it's time consuming, it's expensive, cultures are prone to contamination, and you have biosafety hazards. Particularly with liquid cultures, there's a lot of aerosol generation. So now, to take away some of the disadvantages of culture, mainly the time, the expense, and other things, we have molecular tests, which have come up since the last 2.5 decades. What do these molecular tests do? First and foremost, they detect the presence of Mycobacterium tuberculosis in the specimen. They identify the mycobacterial species as MTB, and they identify drug resistance if it is present. So amongst the earliest of these to come was the PCR, followed by the GeneXPERT or the XPERT MTB, which came in the first decade of this century. GeneXPERT, as you can see, is a very simple test. You have sputum liquefaction and inactivation with the reagent, transfer of stuff into the cartridge, and then insert this cartridge into the MTB RIP test platform. This is the end of your hands-on work. After it is sampled, processed, and you see you get ultimately the readout in 1 hour 45 minutes, which will come in two things. You will get either the presence of MTB detected or not, and if it is detected, then whether RIF resistance is present or not. Okay. Then we have the line probe assay, which came soon after the GeneXpert. Line probe assays identifies the MTB complex. It detects mutations associated resistance to isoniazid and rifampicin, which is the genotype MTBR plus or the enolipar TB, and also the genotype MTBR-SL, which has ofloxacin, amikacin, and ethambutol. Line probe assay has good sensitivity and specificity, particularly when culture isolates are used and they are positive. So what is the sensitivity of all these tests for TB? You have the diagnostic pyramid here. At the bottom is your midget, that is liquid culture, followed by CB-NAAT, that is your GeneXpert, and then the LPA. So GeneXpert is a very good test. It has revolutionized rapid diagnosis and treatment, particularly for drug sensitive as well as drug resistant TB. How? I'll come to that later. So the advantages of GeneXpert are that it enrolls more MDR TB patients on treatment faster. It detects only RIF resistance, but we know that patients with RIF resistance will fail a rifampicin containing regimen. So it can be taken as a surrogate marker of MDR TB. GeneXpert quantifies your MTB load as very low, low, medium, or high. It has the least biohazard risk of all the genotypic tests, and it has good sensitivity both for smear positive, smear negative, and extra-pulmonary samples. There are two major disadvantages of GeneXpert. One, unlike culture, it cannot be used as a monitoring tool because it continues to remain positive even in patients who have successfully completed treatment and are cured. Two, the diagnostic accuracy is critically dependent on the cycle threshold or CT values, which can be difficult sometimes to analyze, particularly for RIF resistance in samples with low bacillary loads, that is MTB low or very low, and I'll come to this later in my talk. Coming to the line probe assay, the advantages are that it gives you rapid results. Unlike GeneXpert, which only gives you RIF resistance, line probe assay can also diagnose INH resistance, therefore giving you a definitive diagnosis of MDR-TB, and the second line LPA can also give you diagnosis of pre-XDR or XDR-TB. There's potential for improved yield of results relative to cultures coming positive, and again there is less biohazard risk as compared to culture. The disadvantages are that there is a risk of DNA cross-contamination. The test will fail if PCR inhibitors, for example, blood, are present in the sample, which can happen sometimes during sample collection. And again, there is a limited number of drugs for which the line probe assay is standardized. Okay, so basically, how do we interpret a GeneXpert? I told you GeneXpert will give you just two things. First and foremost, the presence of MTB. If that is there, then RIF resistance. So if MTB is not detected, there is no question of RIF resistance. If MT is detected, but RIF resistance is indeterminate, it means that the mutation in the RPOB gene, which encodes resistance to rifampicin, could not be determined due to insufficient signal detection because there is insufficient MTB load in the sample. So either the load is very low or low. Okay, if you have MTB detected and RIF resistance detected, then it means that the RPOB mutation is there. This patient is RIF resistance, is likely to fail a rifampicin containing regimen and therefore should be considered for starting treatment on an appropriate regimen for MDR-TB. And you should also do a full first and second line DST to confirm the diagnosis. If your MTB is detected but there is no RIF resistance, that means there is no mutation in the RPOB gene. Therefore, this patient is likely to be RIF susceptible and you can start a regimen for drug susceptible TB. So GeneXpert basically detects, you see, units A, B, C, D, and E in the RPOB gene, which encodes DNA-dependent RNA polymerase for rifampicin. So the GeneXpert probes, they identify RIF resistance mutations in the RPOB gene by shifting their Tmax away from a wild-type reference value. A clear change in the Tmax distinguishes a wild type from a resistant mutant. Now let's just go to some examples of GeneXpert. You see, this is a basic readout of the GeneXpert test. This is how it looks like. On the left-hand side, you have things such as sample assay, start, end time, and date, and patient information. Okay. Then in the middle on the top, you have the most important part. You have MTB detected or not detected, and if MTB is detected, then a comment on the RIF resistance. These will be in red and green depending on what is there. If anything is detected, it will be red, and if it is not detected, it will be green. So you see you have MTB detected, and if it is detected, it will comment on the quantification, whether it is very low, low, medium or high. Here it is medium. And here if resistance is not detected, so it's a green bar. If it had been detected, it would have been red. Okay, below that you have the cycle threshold values for 5 probes. You can see probe A, B, C, D and E, and here's the sample processing control. The CT values are given here, and below that you have the real-time PCR curves. For us as clinicians, this is important only this part. And if you want to cross-check or analyze the report, the parts that are below and how to look at them, we'll go through it. Okay, so basically what GeneXPERT does is that if there's mycobacterial DNA in the sample, it is a PCR based test, a polymerase chain reaction. So the DNA is amplified till a level the target protein can be detected. And this reaction occurs in 3 phases: baseline, log linear and plateau phase. And the reaction is measured in the log linear phase of amplification. So ultimately, cycle threshold means the number of times the PCR cycles have to be repeated before the target protein of interest, in this case RPOB gene mutations, become detected. So if the bacillary load in the sample is high, the cycle threshold will be low because you have to run the test, you have to run the cycles fewer number of times. If it is low, then you have to run the test for more cycles. So the CT values will be high. So this is how it is. So below a certain threshold, you see you will get detection and not detection. Okay, so how do we quantify MTB detection? If the cycle threshold value is less than 16, that means the bacillary load is high. If it is between 16 to 22, it means the load is medium. If it is between 23 to 28, it means that it is low. And if it is more than 28, then it means that MTB was very low. Okay, so just go through a few samples of how to interpret your GeneXPERT and what are the policies. So this is a GeneXPERT. You see here you have MTB not detected. Why not detected? You look at the CT values. On all the probes they are 0. So MTB not detected, a green band and no comment on the resistance. Second thing, second report, you have MTB detected high. Okay, and you have RIF resistance detected. So both are red bands. Is something missing here? Yes, you got it right. The CT values are. So here they are. So you see what was high, anything less than 16. So you look at the CT values here, probe D14, C12, E13, A12, and this is the sample singlet. So you see the software just analyzes the CT values for you. You don't have to do it yourself, but you can correlate easily. So this is MTB high. Now let's look at MTB medium. Again, you have MTB detected medium, so a red bar and no ref resistance, so a green bar. So why medium? Medium was 16 to 22. Okay, so look at this. Probe D21, C20, E and B both 21 and A20. Okay, so this is MTB detected medium. But what is the problem here? You see, sometimes you can have discrepancies in different samples from the same patient at the same site taken a few days apart. Even if the quantification is the same, ref resistance may be discordant. So you see, this is one of my patients. You have MTB detected medium in both samples, ref resistance not detected in the first but detected in the second. Now why medium? I've already told you. You can look at the CT values here. Okay, they are all within the range 16 to 22. But then this is a patient who for 2.5 months was failing on the drug susceptible regimen. So he required a diagnosis of MDR TB. Okay. So the first test came like this and we were not able to change therapy. A second test repeated subsequently showed ref resistance and we were able to start this patient on an appropriate regimen for MDR TB. All right. Then MTB detected low. Low is what? 23 to 28. Okay. So again, there can be discrepancy in the sample. This is a sample of pericardial fluid, an extra-pulmonary sample. So here, the bacillary load is always paucibacillary, that is to say low or very low. So you can get discrepancies in such type of reports. So here you have MTB detected low and no ref resistance. All right. So low was what? 23 to 28. Let's see. This is 28, 27, 28, 27. Again, A is 26. So yes, it tallies. But then again, you can get discrepancies. On the right hand side, you have MTB detected low and ref resistance detected. All right. So you have to be very careful because this gives you a dilemma when you're dealing with the patient. Last and but not the least, let's look at MTB detected very low. Okay, so MTB detected very low, MTB RIP resistance detected. So you have two red bands, and then you see you have again two discrepant reports. Very low was what? Anything above 28. So you see a probe B is 33, C is 32, E is 32, B is 33, probe A is 31. Again, this was a patient of smear positive pulmonary tuberculosis, a suspected case of drug resistance. So you see, you get a dilemma sometimes when you do GeneXPERT upfront. All right, so you have to use sometimes your clinical assessment. Most of the time, what we do is repeat the test or the sample itself. So all I'm saying is that molecular methods are good methods. Yes, they've revolutionized the turnabout time for starting MDR TB treatment. Initially, when I joined the TB control program, it would take 2 to 3 months to diagnose. Nowadays, you can do it in a jiffy, and you can start treatment also, you know, rapidly with these molecular tests. But all said and done, they have their diagnostic limitations. I've shown you what some of those are. Just to briefly enumerate, there's variable sensitivity in extra-pulmonary disease, smear-negative pulmonary disease, TB-HIV co-infection, and TB in children. So all said and done, they cannot be recommended to replace conventional methods like culture entirely in select cases.